Morning, everybody. Welcome to day 2 of the 2026 West Oncology Conference. It's good to see you all again this morning. Just as a reminder, we do have an exhibitor raffle bingo going on. Nobody turned one in yesterday, so there's still a chance. If you guys fill it out, turn it into the reg desk, you can be entered in for our raffle. You can win a gift card. We have some great sessions planned today. I do encourage you all to engage, ask questions. If you have questions, you can raise your hand and I'll try to run over and give you the microphone so everyone can hear you ask your question. If you need any assistance throughout the day, you can come to me or my team that's at the reg desk, and we're happy to help you guys out. But for now, I would like to introduce one of our program chairs, Dr. Brad Summer, who's going to say a few things, and then we'll get kicked off for the morning.
Thank you. Thank you so much. Thanks, everybody, for coming out so early on a Sunday morning and participating. We have a really amazing day of speakers and great topics. So I'm really excited about the rest of the day. So we look forward to seeing you through the day. We are going to kick off with the GU morning, which is, we have people clapping here. Very nice. But this is great, and so we're going to talk about this morning. We have Dr. Srinivas from Stanford, who's visiting us. Thank you so much for coming. And she is a GU oncologist from Stanford University, who we're very excited, and she'll be talking today about updates in non-prostate cancer GU.
Good morning. Thank you all for being here. Thank you for the invitation. I'm excited to talk about some updates in bladder and kidney cancer. So this was what I had this is the outline for what I was hoping to cover in the next 20 minutes. We'll talk about adjuvant therapy in kidney cancer and talk about the most recent trial with pembrolizumab and belzutifan as an option. We'll cover something in refractory renal cell cancer. For the first time, we have a doublet, lenvatinib and belzutifan, pitted against an active TKI. And then I'd like to spend the second half of my talk talking about perioperative therapy in bladder cancer. So let's start off with adjuvant therapy in kidney cancer. You know, we have had, in the immunotherapy contemporary era, there have been 4 randomized trials looking at patients in the nephrectomy, post-nephrectomy setting. 3 out of the 4 trials are negative, and I'm just going to dive a little bit deep into the positive study and where we go from here. So these are the 4 studies. Keynote 564 was a randomized study looking at adjuvant pembrolizumab for 1 year following nephrectomy. That was a positive study, but if you look at the other 3 studies listed side by side, Emotion 10 was almost identical in design to Keynote 564, but here a PD-L1 antibody, atezolizumab, was used, and you can see completely negative, right? There's 0 space between the 2 curves. Checkmate 914 was a randomized study looking at ipi-nivo for 6 months against placebo, and that was a negative study. And then there was also a study called Prosper, which gave preoperative nivolumab and then took patients to a nephrectomy and was a negative study. So 4 studies, 3 which were negative, and Keynote 564 was the only positive study. So going to dive a little bit deep into Keynote 564. These were the high-level data that there was an improvement in overall survival, hazard ratio of 0.62. So first ever study to show an improvement in OS. There was an absolute difference of about 5% at 48 months, favoring pembrolizumab. DFS was again positive with a hazard ratio of 0.68. And of course, anything comes with a price. Pembrolizumab was associated with higher grade 3 to 4 toxicity. What are the controversies with Keynote 564? You know, people worry whether with longer follow-up, whether the OS will remain. The absolute benefit of 5%, does that justify putting patients through 1 year of adjuvant therapy? There is a possibility of overtreatment, and I'm going to come back to that in a bit, where majority of patients, could be cured with nephrectomy. Are we doing them any benefit by giving them a full year of adjuvant therapy? If you look at Keynote 564, 1 in 5 patients came off because of toxicity. And then especially we now know that the endocrinopathies that people have could put them on lifelong therapy with steroids if you were to have an adrenal insufficiency, etc. The biggest controversy is that this study, a lot of people feel that the control arm didn't get post-therapy IO, and did that impact the overall survival? And I think I'll come back to this over and over again in kidney cancer, that we lack a biomarker for selection, and that's a huge issue to where there is overtreatment. And one of the other things that I do want to point out is that by putting somebody on 1 year of therapy, if they were to fail, are you impacting their response to therapy in the metastatic setting? We know in kidney cancer, you only get one chance at an IO. Have you lost that, and are you doing patients not a favor? Nonetheless, despite all of this, the FDA approved pembrolizumab for adjuvant therapy for 1 year in 2021, and I'll say it's actually been embraced quite a bit by the community, that there are a large number of patients getting adjuvant therapy. So on this background is where we have LightSpark 022. So this is a randomized trial, now assuming, even before pembrolizumab was approved, that pembro is the standard of care arm, and they are now adding 1 year of belzutifan, our oral HIF2 alpha inhibitor, on top of pembrolizumab. So here is the eligibility. Who were the patients who came into the study? Clear cell RCC, no prior systemic therapy, should have had a nephrectomy, and they kind of built in identical entry criteria to Keynote 564. So intermediate high risk would be defined as patients who have PathT2, so tumors that are greater than 7 centimeters, but with a sarcomatoid component, pathologic T3, and then high risk would be if you have T4 or node positive patients. All of these trials include M1 NED, so these are patients who may have had a lung met resected, and then they were allowed to enter the study. The primary endpoint was DFS, secondary endpoint was OS. These are some patient characteristics. I don't have a whole lot to point out, very classic for an RCC trial. 3/4 are men, 15% from the US, 60% were of Caucasians, majority of patients with a 0 ECOG. If you look at the risk category, about 80% were that intermediate to high risk, and M1 NED was about 10%. Sarcomatoid in about 10% as well. Here are the results. The trial did meet its endpoint, so DFS favors belzutifan and pembrolizumab over pembro. You can see that the hazard ratio is 0.72, good statistical significance. OS is too immature, not enough events, so we have to wait for that data. What are the adverse events? Clearly for belzutifan, for those of you who are not familiar using this drug, it has a class effect of anemia and hypoxia. So this is what happens when you give people belzutifan, and you can see up here that anemia was quite common, leading to belzutifan dose reduction and dose interruption. Patients needed a transfusion, patient needed erythropoietin support when you give belzutifan. So definitely a new side effect. Hypoxia is not, people have a drop in their oxygen saturation without much true hypoxia, but that's also a side effect that patients should be counseled on. So what are my conclusions? That there is no OS yet for the addition of belzutifan. I think, again, everything that was said for Keynote 564 holds true here too. There is a risk of overtreatment. Belzutifan toxicity is somewhat unique that we need to keep that in mind. There is added financial toxicity with yet another oral drug. And again, the lack of biomarker selection comes back to haunt us. I want to put up for you here, how do you assess risk? Unlike the luxury that you have with breast cancer, we don't have that sort of big nomograms that have been helpful. I like this one the best. It's called the Assure RCC nomogram, and it takes into some of the things that are of value, right? The size of the tumor, grade of the tumor, presence of necrosis, is there a sarcomatoid component, is there node positive? And then I just put here two patients, with different characteristics, right? And if you plug in these numbers, for the first patient, that risk comes back as a 5-year DFS of 10%. I mean, that's pretty high risk, right? I would feel much more comfortable offering this patient adjuvant therapy as opposed to the patient on the right. His DFS is 61%. So with no therapy, there's a 60% chance that this patient is not going to need any additional therapy. What is the value added for a whole year of treatment? So I think you need some starting point without a biomarker selection. And I would certainly encourage us who see these patients to sort of put some thought into giving patients a risk assessment before we commit them to a year of therapy. So I want to move on to refractory RCC now. The 4 treatments that I've listed are NCCN guidelines for frontline metastatic RCC. It's either dual IO with ipi-nivo or IO with a TKI, and these are the options. Cabo-nivo, len-pembro, or axi-pembro. So what do we do today for patients with second line? If you were a dual IO believer, if patients, when they relapse, you would give them one of the following. It could be cabozantinib, lenvatinib with everolimus, tivozanib, and belzutifan exists as well. So you can see this is what we do based on what else is available to us, and these are listed in the NCCN guidelines as well. So on this background, we have for the first time a doublet, lenvatinib plus belzutifan, and it's being compared to cabozantinib as a monotherapy. So really a very active comparator arm. This is LightSpark 011. Who came into the study? They were unresectable advanced RCC patients with a good performance status who should have had less than 2 prior systemic therapy. Patients were randomized, pretty large trial, close to 700 patients, randomized to lenvatinib at a pretty high dose, so 20 milligrams per day, along with the standard FDA-approved dose of belzutifan at 120 milligrams. And the comparator arm, again, was cabozantinib as 60 milligrams per day. The primary endpoint was a dual endpoint with rPFS as well as OS. Here are the patient characteristics. Again, it's very classic for second, third line RCC patients. They were patients who had had prior therapy. You can see in the bottom, number of prior VEGF TKIs. More than 50% had 1, and a small fraction had more than 2 TKIs. So the trial was a positive study. I mean, I was surprised that I predicted that the hazard ratio would be around 0.7. There was no improvement in overall survival yet. The overall difference was about 4 months favoring the doublet with lenvatinib and belzutifan. What were the response rate? There was a higher response rate of around 50% for the doublet compared to 40% with cabozantinib. Much of those were partial responses. But I think the thing that caught people by surprise that kind of pushed for this therapy was the duration of response. You can see that it was almost double, favoring the combination with lenvatinib and belzutifan compared to single agent TKI. So, of course, when you add another drug, it is going to come with higher side effects. But overall, most of it is from the TKI, and belzutifan itself didn't add to a whole lot more. You can see up here that discontinuation was not that large. I mean, it was slightly higher. It was maybe higher in the dual combination, but most of it comes from the TKI rather than belzutifan. So my conclusion, this is the first randomized trial in this refractory setting compared against an active TKI like cabozantinib. But many options exist. Till you see an overall survival, is it justifiable to add 2 drugs? Maybe in a certain patient population, I like the duration of response was impressive to push this regimen, but there are many options for these patients. I think you have to weigh in the toxicity with the duration of response, but I think it's certainly a viable option for some, where you may consider doing the doublet over monotherapy cabozantinib. So now I'm going to spend the last 10 minutes talking about muscle-invasive bladder cancer, and literally this is such a changing space that I wanted to talk a little bit about this in the next 10 minutes. So what did we know pre-Niagara was a big trial that I've depicted for you up here. But prior to Niagara being read out, the standard of care for patients with muscle-invasive bladder cancer was, we would think about them as to whether they are cisplatin eligible or they are cisplatin ineligible. If you were cisplatin eligible, you got platinum-based chemotherapy with either gemcitabine and cisplatin or dose-dense MVAC, and then you went on to getting a cystectomy. If you were cisplatin ineligible, there was no therapy offered, and you would go directly to a cystectomy. Then came along Niagara. So what was the trial designed for Niagara? Patients with muscle-invasive bladder cancer, again, it was the cis-eligible patient population, were randomized to the sandwich approach. So patients were randomized to either cisplatin gemcitabine with durvalumab, so first time integrating immunotherapy, versus the comparator arm was cisplatin and gemcitabine. Patients got 4 cycles. They would go on to getting a cystectomy. And then there was also an adjuvant component. Patients would then get durvalumab for another 8 cycles. And the primary endpoint for this study was an event-free survival. They looked at pathologic CR. So here are the results that I've highlighted in bold for you. The event-free survival was an impressive hazard ratio of 0.68. The overall survival was 0.75. And we saw that patients who got this IO chemotherapy had a pathologic CR of 37%. This was FDA approved in 2025, and I would say quickly adopted. So everybody who was cisplatin eligible got the addition of immunotherapy and then went on to getting cystectomy. Then EV Pembro came into the scene and was being a huge disruptor, really in this field. So now you're looking at cisplatin ineligible patients. And again, as I reminded you in the previous slide, there was no therapy for these patients. They would go directly to cystectomy. So this trial, EV303, took patients who were cisplatin ineligible, either they refused or they were not a candidate for cisplatin, and they got randomized to either EV Pembro, so 3 cycles of EV Pembro, followed by a cystectomy, or patients who went directly to a cystectomy and observation. I put up the top curve for pembrolizumab. They did include a small number of patients who got single-agent pembro, but the real comparator was between the observation versus the EV pembro arm. EV pembro has been such a successful drug in metastatic disease, so not a big surprise, but here are the results. Event-free survival with a hazard ratio of 0.4. So pretty impressive practice-changing data. Hazard ratio for OS at 0.5. And you're now looking at PathCR of close to 60%. So with the Niagara study with cisplatin, gem, and durvalumab, PathCR of 37% I showed you in the previous slide, so now up to almost 60%. And 2-year event-free survival is almost double for the EV pembro arm. So this just got approved in November of last year, that now I think EV pembro is routinely offered for patients who are cisplatin ineligible. In parallel was this trial, EV304, now looking at cisplatin eligible patients. So here is the randomized study looking at EV pembro given for 4 cycles, or the control arm is your standard of care cis and gem. So this then, now everybody does the sandwich approach, so you get 4 cycles of preoperative therapy, then go on to getting a cystectomy, and after that, you would go on to getting additional cycles of EV pembro. So the EV pembro is for another, so if you got 4, you get another 5 more cycles. So it's a total of 9 versus observation. And again here, similar endpoints. You can see the results. Event-free survival, again, hazard ratio of 0.5. The median is not reached in the EV pembro arm. Overall survival, again, hazard ratio of 0.6. And PathCR, almost similar to what you see in the cis-ineligible patient population. So now you don't need to think whether somebody is cisplatin eligible or not. You just have to think whether they are IO eligible, and most patients should now get EV pembro, followed by cystectomy. So here is a comparator table between the Niagara trial, EV303 and EV304, just highlighting the event-free survival going from 0.68 for Niagara versus Keynote EV303 at 0.4, and in the cisplatin eligible population at 0.5. You can see overall survival again, 0.5 for the EV-containing arms, and the PathCR again, 37% with Niagara, around 57% with the EV pembro-containing regimen. The number of cycles, it's a little confusing about what's the component of neoadjuvant versus adjuvant. I think the big question that all of us in the field have is, what do you do post-cystectomy? If somebody has T2, should they get additional EV pembro? That seems like a lot in terms of toxicity. That's how the trial was designed. So if you talk to the authors, they tell you, just follow the study, right? So I think the question of post-cystectomy, if you were pathologic T0, why should you get more treatments, right? So I think that question continues to remain about, what do you do for people post-cystectomy? What's the optimum management? So here comes this trial. This is fresh off the press from 2 days ago. So May 14th, this was a press release with this trial called Volga. So what Volga was, took cisplatin ineligible patients, okay? Very similar to the EV pembro trial that I showed you. They then get randomized into one of these 3 arms, now looking at durvalumab plus tremelimumab is the first arm 1. Arm 2 is just durvalumab plus EV, and arm 3 is no neoadjuvant therapy. They then go on to getting a cystectomy, so similar sandwich approach. But look at arm 2 and arm 3 is what is really statistically designed for a comparator. So following EV durvalumab, they get a cystectomy, and then they go on to getting randomized to durvalumab alone for a year. So this trial is positive. That's all that we know, that it's met its endpoint for EFS and OS of the doublet compared to control arm. So I think this changes things a little bit. You could now consider giving just IO alone. Certainly most of us feel that pembrolizumab monotherapy or durvalumab monotherapy may be less toxic compared to the addition of EV. So certainly it's an option. So here are my conclusions, that I do believe today that most patients with muscle invasive disease should be getting EV pembro, irrespective of their platinum eligibility. What the contribution of neoadjuvant versus adjuvant, I think, is a little unclear. The toxicity of EV post-surgery is real. How much should we give? Do they need EV? How do we manage toxicity? I think those are real. I think post-neoadjuvant therapy, you then have to decide on local therapy. Should it be surgery? Can people get by with radiation as their consolidative therapy? I've not brought out the radiation data, but there's a lot of interest and a lot of enthusiasm to not do a cystectomy and instead do radiation as your consolidative therapy. And then I 100% believe that post-cystectomy, we are still not clear about what's the best therapy. We need ctDNA to guide therapy. And I think just yesterday, the FDA approved atezolizumab for adjuvant therapy based on ctDNA. So if you were ctDNA positive, atezolizumab is now an FDA-approved drug. So, since I made the slide deck, I changed it 3 times just to keep everybody updated. So it's such a rapidly changing space that it's exciting and have many options for our patients. So I think I'll stop there and stay on time.
That was amazing.